everybody was, or when they joined, they're on mute already, so you shouldn't have to worry about your phones. We're going to have a Q&A at the end of the session here. So if you have any questions, if you'll post those in the Q&A part of the WebEx, then we'll take care of those at the end. So we'll go ahead and get started here. And Dr. Osborne, go ahead and take the ball.
All right. Hi, everybody. Welcome to our PCP division meeting for the fall or the early fall. So glad that everybody's with us. Thanks very much for joining us. I'm going to be talking about just a few topics here for the first little bit of our meeting. I'm going to talk a little bit about an incentive summary for the year and a little bit of discussion about what's going on this year. Talk to you about a new analytic platform that we have within THN. And also talk about some pilot projects we have to try to control and lower the cost of care. And then a few odds and ends and a brief look at our future. So a lot to cover here. So here's a history of incentives in THN. You will notice that we had pretty good incentives for the first few years, and we're going to actually have a record incentive this year of $9 million payment. And so that will be coming soon. In fact, it might actually be already in the mail, and if not, it's going to be put in the next day or two. So I know you've heard it's in the mail, but in this case, it's really pretty much true. We'll give you some information about your practice, numbers of gaps you've closed, et cetera, et cetera. So we'll show you how that all unfolds. So we're very excited about that. Thank you for all your work. I do want to remind you, of course, that in 2018, and 19, for those years, you get a APM bonus. So for the 2018 year, that was paid in 2019, and we'll get another APM bonus. And we estimate that's $4 to $6 million all told here. And so all told, being a participant in THN is really beginning to pay off, I think. So thanks for all your work and all of the hard work by your staff as well as our THN staff. I thought you might be interested in some of the ways in which this got developed and how it got divided. So if we look at the different plans within THN, we see that there are 4 major plans that contributed to our margin and our incentive payments. NextGen, United Healthcare, Humana, and HTA. Excuse me. And NextGen was about 16 or 17%. United Healthcare was about 36%. Humana about 25%. HTA there at about 18%. So that's where the dollars came from. You can see over on the right that the the primary care to specialty ratio was about equal numbers of dollars this year as it was last year. And then, but because we have about 4 times more 4 times more specialists than we have primary care physicians within THN, then what we end up with is about a 3.8 to 1 ratio of primary care payments to specialists on an average basis, which we think is very appropriate and the correct ratio to have. In terms of how this developed, you can see that we had a pool of about $4 million for our primary care. About $317,000 of that was unearned or left behind, if you will. We'll talk about that in just a moment, where that came from and what's going to happen with it, leaving a payout of about $3.7 million. For our specialists, about $3.86 million was allocated to their pool. About $941,000 was unearned because of their failure to reach certain metrics, engagement, referral management system, project work that were their tasks, and so they paid out about $3 million. If you want to know what the averages are, it's about an $18,000 average for our PCPs and about a $3,000 average for our specialists. So what about this part that was left behind? You can see that most of this is due to the fact that gaps were incompletely closed. So we did a pretty good job on our gaps. I'm not going to say this is bad, but in order, you'll recall that there's a baseline fund and that there's a full margin fund. And in the baseline fund, basically all the money gets distributed according to all the closed gaps. But in the full margin fund, if there are remaining open gaps, then that money is held back that year and goes into the physician incentive distribution for the next year. And so in summary then, what we see is that these two amounts, the 317,000 here and the 941,000 here, go down to here. It's about $1.2 million that we have available for distribution next year based on work you're doing this year. Now, the other thing that we did, because we were making our decisions about distribution of our incentive this year when COVID was hitting, is we did not distribute all the money we had available for physicians, which is much like we did last year. We didn't distribute everything last year. So we held back about $3 million. So now, going into this year that we're working on, we have about $4.2 million already available for physician incentives. So we're very excited about that. And as I will tell you later, well, I'll go ahead and tell you now, we're going to probably have a greater than a $9 million incentive payout, I would predict, based on how we're looking for this year. Now, the other thing that's an advantage is this issue of our macro payment. You might recall that when macro came out, you had a choice, basically. You could participate in an advanced alternative payment model like THN, or you could decide that you wanted to go on your own and do the thing called MIPS, the Merit-Based Incentive Payment System. And what they told you is if you're really good, maybe you'll get 9%, up to 9% on MIPS. Well, how did the groups do that did really well in MIPS? They got 1.59 to 1.79% payments. The reason for this is that in order to get a payment in the MIPS world, somebody's got to do poorly. So people have to do poorly to get a negative because it's budget neutral. And so we're really excited about this. We think this is another good reason to participate in THN. It's kind of an extra 5% for your participation and your work, and we appreciate it. Comes out of CMS's pocket, so it's even better. And it's much better than what they're trying to do in the MIPS world. So that's a little summary for 2019. So let me turn now to 2020. So again, we've got this amount held back of about 4.2 million, and we don't know exactly what's going to happen for 2020, but I'm going to say that it's likely to be greater than the 9 million overall. As usual, we have a baseline fund, and that baseline fund is predominantly earned by closing gaps on patients. We're also using a PCMH bundle, which is a combination of how many annual visits do you do on your patients, how many transitional care management visits do you have on your discharge patients, and whether you just see your patients. So we're going to give them credit for just seeing people, because we know some people don't want to do an annual wellness visit. So we want to give you credit for that. And also the use of the referral management system for Proficient. We need every practice, every primary care practice to log in at least weekly. Now, for some of you big practices, you might think, what, only weekly? But for a solo practitioner, that might be enough to get all their consults in for the week. We're going to leave that up to them. But for many of us in larger practices, we have multiple people entering the referral management system multiple times a day, as it should be. Now, then we go to a full margin fund. If the baseline fund does not exhaust all the funds available, 75% of that will be based on gap closure. 15% of that will be based on what we're calling a RAF adjusted patient load, which is basically the sum of all the RAF scores for your patients. So the better you do in diagnosis, coding and all that, then we'll give you credit for that, and you'll get a larger portion of that fund. And then we're doing 10% on access. And of course, I know that makes primary care physicians nervous when we start talking about access, but this is a pretty easy target for you. It's basically being open to some new patients. So that would mean at least 2 patients per plan, or this is an or. I didn't write the or in, I apologize. These are not all, you do not have to meet all these. So let me be very careful and say that. After each line, it should say or. Same day appointments, at least 2 a day across all of your plans. A provider in the practice answering calls at nights or on weekends. Now that could be after a phone triage by the nurse, but it cannot be that the triage nurse just tells your patient to go to the emergency room. We need a provider to talk to our patients at night if they go through the triage process. And then of course, whether you use virtual visits. Now that's pretty easy because almost all of us are using virtual visits. So I think almost all of us are going to hit access this year without much more work. If you haven't been able to get your virtual visits up and running, then you'll need to use one of these other methods to meet this quality metric or meet this incentive metric. So that's a little quick summary for the 2020 incentive. All this was sent out in the early part of the year, so we hope you read it, but I did want to review it. I thought it was a timely thing to do as I reported the 2019 results. Now, we are thinking about 2021 already. So we're already thinking about next year. So of course, we're going to probably have our quality gaps showing up as a major part of our incentive plan for our primary care physicians. probably a little bit on engagement, attending a division meeting like you're doing tonight, RAF meetings, and our new program called Elite Primary Care, where we're trying to come out regularly to our practices. We need our providers to meet with us occasionally so that we can help give you important information, have important discussions, and learn from you about what you're doing to do better care so we can pass that on to other people. And we're likely to have something related to advanced care planning. And the other thing, if we can do it, is thinking about some kind of survey. Probably not an external survey because they're expensive, but maybe something internal. We are increasingly in the future going to be measured on CAHPS and HAAS surveys. And these are, you know, how well did your doctor explain things to you? How well did your provider understand your problem? Just lots of other things that aren't necessarily just closing gaps, but these are going to be an increasing, I believe, up in the 35 to 40% of our incentives in our Medicare Advantage plans and in our Next Gen program are ultimately going to be related to surveys. So this is a very important thing. And so we'll be thinking about that and how to do that as we move forward in 2021. Now I want to change gears a little bit. One of the things that we've had in THN for years, as you know, is KPN, and it's the source of our point of care tool. It's a very good platform for reporting on quality metrics. It's not perfect, but it's pretty good. And so we've been recognizing for many years that we had a deficiency in our analytic and reporting tools. And so what we have been doing in the last 8 months now is looking at a different platform, not to replace KPN, but to supplement KPN and to analyze really more of our utilization. And so we need an enhanced ability to do that. We have data, but it's really hard for us our analysts to create dashboards and other things for us to be able to use effectively. And so we started in December with a project where we decided that we would look at finding a platform that would allow us to understand not just the quality gaps and maybe even build on KPN, but also understand RAF and utilization better, because these are the keystones of our success. We needed a platform that would provide us quick answers to questions, particularly the common questions that we need. Where are our costs going? Dive deep into certain areas, that kind of thing. We needed the platform to be able to handle Medicare, Medicare Advantage, commercial and self-employed plan. For us, at least right now, not too much on Medicaid. We needed the platform to be able to help us with care management, including risk stratification. We wanted a physician dashboard so you can see what's happening with your panel of patients. We wanted a leader dashboard so we can see the entire network. And that platform needed to be able to ingest the data that we've already collected from KPN, additional claims data, the lab and radiology data available from our local companies, as well as to connect to EMRs covering most of our patients. And also we want to be able to provide data for THN and non-THN patients. We actually looked at a total of 7 different platforms. It didn't take us long to get rid of 4 of them. I won't read through what the different ones were, but you can see what they were. We were left with 2 very similar platforms, Arcadia and Innovacer, and a slightly different platform with a different program called Maestro, which was associated with a company called Lumeris out of St. Louis. We decided to drop Arcadia. We liked Innovacer a little bit better. These are both fine groups, but it was just getting too confusing because Arcadia and Innovacer were so similar. So we got rid of Arcadia from our consideration, and then it was down to Innovacer and Maestro. We had them come back in and spent an extensive amount of time with them. I shouldn't say they came back in. Of course, they came back in remotely. And we spent a considerable amount of time, a whole team, looking at this. And we used innovation ability, cost, practice transformation support, the actual platform functionality of the platform itself. How well does that work? And references to help decide. And we have selected Innovation. And this is going to allow us for the first time to routinely produce physician dashboards that include not only quality, which we are able to do with some difficulty, but able to do with KPN, but also the cost of care, which we think is critical for our success in the future. Just to show you quickly how this will work, Innovacer will collect data from all kinds of places. You could add here KPN as one of their sources because we've already got that data. It's put into a single platform and it creates a single record. And then they have a series of apps that they use on top of that. The ones for us that are most important are in-graph. That's going to be where we see our physician reporting dashboards as well as our dashboards for THN leaders and staff. our care management platform, which will enhance the ability to do our care management, both within the Cone Health employed physicians, as well as we hope as we can use parts of it with our independent physician practices. EndNote, which you see listed here twice. EndNote's a very interesting thing for those of you who are intimately familiar with our point of care tool. EndNote is actually a thing that sits on top of, if you will, but not integrated into your EMR. And as you're looking at patients, if EndNote has a message for you about that patient, a gap that's open, a RAF issue that's open, or a communication from a care manager, you'll see a little icon. And when you press that icon, over slides a thing outside your EMR, but in your screen, single sign-on. You don't have to worry about going to another system. It just slides over and it tells you that information for your use as you're seeing the patient. We think a good thing for us to be considering using in the future. And there's some other apps that I won't go through entirely. We're very excited about this because we think for the first time we're going to get a handle on where some of our costs are. Now, we haven't been completely ignoring costs. We do have abilities to look at areas of high cost within our network. And I want to share with you 2 areas where we have high costs and some of the strategies we're going to use to try to solve those because they're going to involve you. The first one is the musculoskeletal conditions, and the second is in considering our highly complex, frail patients. If we look at, and I know this is small for you, you might not be able to see it very well, but if we look at our next-gen utilization compared to the average and the best-in-class utilization of about 50 plus ACOs in America with whom we are in a collaborative, we see some very interesting stuff. If you look at this percentage right here, this is our performance relative to the average, and this is our performance relative to the best-in-class. And so what you see here is, for the most part, we're average or slightly, in this case, below average, which of course means we're above average because you want to be below the mean. Whether that's inpatient admissions, ambulatory care sensitive conditions, bypass, knee replacement, we're lower. But there's 2 things that stick out a lot, and it's back surgery. All right, we have a lot of back surgery going on in our network. Now, we've extrapolated this to our entire book of business. If we were to look at the excess cost, if we would look at the cost for musculoskeletal conditions across our entire book of business based on what we see in NextGen, we would see that we have a $45 million spend on that. And if we were to just reduce that by 20%, if we were to think that maybe we aren't supposed to be twice as busy doing back surgery as other communities in ACOs in America, then we could see a reduction in cost and perhaps some even better outcomes for our patients, because maybe some of these patients, I'm just not so sure. So the question is, how do we do this? So how would we go about this idea of trying to reduce this spend? Well, the first thing is we cannot depend on our orthopedic and neurosurgery colleagues to do this. By the time a patient gets to them, they're usually in the idea that, that the patient is already in the idea of, doctor's got to do something to me to fix me. And the reality is that the solution is going to have to start with our primary care physicians. Now, some of this information I'm giving you on this slide, I'll be honest with you, is a little dated. So what I'm telling you now is a little bit less true of those who graduated from residency in the last 10 years. But certainly it was true for old people like me, and the vast majority of our primary care physicians were not trained in the last 10 years. But just to let you know that 20 to 40% of the visits in your offices are actually due to musculoskeletal conditions. But numerous surveys in the 2000s, numerous surveys revealed that PCPs really lacked a lot of confidence in how to reliably treat musculoskeletal conditions. And the remarkable thing is that most medical students never had a course in musculoskeletal medicine. Not only that, those who went on into internal medicine, family medicine, pediatrics may not have had, up until about 10 years ago, some of the emphases on musculoskeletal care that have been applied more recently. So this is a big problem. I think we've got some providers that are probably a little shaky on this and not sure what to do. So we are going to do a pilot with a company called Integrated Musculoskeletal Care. And then we're going to specifically train a cadre of primary care physicians to guide patients through what is called the Joint Strong Step Therapy. Joint Strong is really interesting. It's actually an app, and it's actually free. If you have an ache or pain, I would invite you to look at Joint Strong on the app stores and look at it. To be honest with you, I actually had some lower back discomfort that had been nagging for me. So I had went through the Joint Strong step therapy on my own, and lo and behold, my back feels better. I wasn't near surgery, by the way, but you know, it's pretty impressive. But the Joint Strong step therapy basically revolves around trying to get our primary care physicians confident in their recommendation that they can just have the patient do self-care, conservative care, or whether they need specialty care. That would be injections or surgery. And so we will shortly be starting a pilot study by offering this training to a group of PCPs. And so there's more to follow on this. So we're excited about this as a possibility to get our patients care earlier, because we think that the reason we have so much spend in this area isn't, we're not pointing fingers at our neurosurgeons. We just think that maybe in our community, we have not been as effective at treating low back pain as we could be. And it's similar for other joint disturbances as well. The second thing that we're going to do is talk to our physiatrists and maybe involve our physiatrists or physical medicine or rehabilitation doctors some more. There was a publication in Spine in 2013 that showed after an initial evaluation by a primary care physician, if there were no red flags, and you know what those are, fever, history of cancer, trauma, stuff like that, things that would make you worry more that this isn't routine back problems, that referring to the physiatrist resulted in a 48% reduction in surgical consultation and a 25% reduction in spinal surgery. Most of the patients were very satisfied with their consultation, and their long-term outcomes were very favorable. So we're beginning to work with the physiatry groups in THN to assure that they're prepared to receive initial consultations. And the goal for that consultation is not to immediately run to an injection, but to treat the patient conservatively and try to avoid that by some of the physical therapy, acupuncture, other methodologies that have been shown to be effective. So more to follow on this. So that's how we're going to begin to address the musculoskeletal cost. What about improving care for our frail elderly patients at home? So you know this pyramid of risk. The top 5% of the people spend the most money. We've tried for years to try to do things for these people, and we have honestly not been successful. We do not know quite what to do about these people. So some people have said we should just leave them alone. Don't worry about them. We should just go to the rising risk people and try to treat those people. And that might be right. But many of these patients are frail and immobile. They have really a limited ability to get to your office when they have a need. And they are very likely to have poor and prolonged outcomes when they go into hospitalization and skilled nursing. You don't need me to tell you that. You already know that. You're thinking right now of the patients in your practice that meet this. Standard care management strategies and home health strategies have failed to bring us reliably measurable outcomes in terms of quality of care and reduction in cost. Now, we have great stories. We have great stories of people being helped immensely. So this isn't to say that our home health colleagues and our THN care managers don't do a good job. They do a fabulous job. But it's just not been quite enough for us to really see an effect. And so the question is, is this because we're trying to provide these services to the wrong patient, or is it because the wrong service? So our assumption going in is that these are the right patients to focus on, but we have done it with the wrong services. And I would say maybe not wrong, but maybe not quite adequate. If you think about care management services, they're usually comprised of nurses, social workers, and in our cases, pharmacists. And again, they do outstanding work and they make a difference in people's lives. But there's two things that they lack. They lack rapid provider contact, the ability to rapidly get in touch with people, and I mean within 15 to 30 minutes if there's a problem. And they also don't tend to eschew physical therapy. They don't tend to approach that issue very well. And so these patients often have sudden declines, and they need a provider to evaluate them quickly. And you've had these calls over and over again, haven't you? You've had the patient call, or the daughter call, or the son call, or the husband call, or the wife call, or whoever, the caregiver calls and says, the patient is sick, they've made a turn for the worse, and you're sitting there with a busy day, lots going on. And what's our response? Well, can you bring them to the office? Well, they can't get in the car. Well, you can bring them by ambulance. It just messes up everything. So maybe to the ER. When they go to the ED, they're likely to be admitted. When they get admitted, they actually become more frail, more immobile, and now they're off to a skilled nursing facility. It's just that cycle that goes on. These people need provider intervention and evaluation quickly. They also have ongoing mobility and frailty issues, and they need consistent support to preserve and enhance their function and mobility. You also know these patients. The patient that you did home health on, and they got remarkably better, then home health PT has to stop, right? Because they can't keep seeing them if they've plateaued. And down they go. My mother's in a memory care unit, and we see this happen to her all the time. She works with physical therapy for a while, then they have to stop, and she deteriorates. So this is what we're seeing. So we are organizing a pilot project with Remote Health. And Remote Health is a small group of providers, a geriatric nurse practitioner, a physical therapist, and a nurse, and they're going to hire some more nurses. And their goal is to care for people at home and to have them avoid the emergency department, hospital, and SNF. So how are they going to do this? They want to work with you, or we do have some patients that don't have primary care physicians. They're going to work as the primary care physician to provide an initial assessment at home to try to help improve the patient's mobility, safety evaluation, et cetera, stabilize their medical issues, and then provide rapid in-home assessment and care when needed, both by telehealth strategies with the nurse in the patient's home with a tablet, and seeing the provider, or hopefully the provider can get there, just either one. They're going to work with advanced care planning. Of course, they're going to work with our care management staff. Now, this pilot was developed in consultation with a group of primary care physicians that we got together about 10 years ago, last December, when it was pre-COVID and life was calm and everything was normal. It does seem like 10 years ago, doesn't it? And so we worked with those PCPs to kind of ask them, what would help you? So I will tell you that in the middle of this came COVID, right? And so Remote Health for the last several months has been working with Heart Care and with Health Team Advantage to see people quickly when needed. And there we could truly tell you stories of ED visits and admissions and SNF stays that have been prevented, and also some moves toward hospice when available or when appropriate. So they're going to serve about 300 predominantly next-gen patients, a few HTA patients. We're going to try to offer these services to them. So what am I going to ask you to do? The first thing I need you to do, and we'll communicate this with your administrators, is to tell your staff about Remote Health. Because the first thing a patient's going to do after they get a call from Remote Health is call your office and say, do you know who these people are? Please have your staff say yes. And if you would, please have your staff say yes, give them a try. They don't have to keep using their services if they don't like them. I'm pretty sure they're going to like them. Have them give them a try. And then Remote Health will be communicating with you when needed. We're not trying to replace you. We're trying to help you take care of your most difficult patients. As we get used to this, we might have opportunity for you to refer patients into the system. I will tell you that because of the small number of providers or clinicians in this organization, we are going to have to geographically limit the panel to mainly Greensboro zip codes right now. And we will also be alerting you to who in your panel, your next-gen panel, is going to be contacted by Remote Health. So a pilot, and let's see if it works. We are excited about what could happen. We're very pleased with the work that occurred with the Heart Care folks and with the Health Team Advantage folks that were referred to. All right, now got a few odds and ends. We're getting toward the end of my little discussion here. A couple of odds and ends. We have a THN app. We just wanted to tell you about this. If you go to, this is the App Store version, or the App Store where you would find it. And you can go to it, and when you open it up, you'll see this page, which is not the most updated one. There's actually an updated front page right now. And you'll see updates that you've gotten by email. If you said, wonder what that said last time I got that announcement, you can go here and get this update. If you click on directory, you'll see this. It looks like Amy's in every practice in our community. But the nice thing is that what this is you could put in your practice name and find out who your practice performance specialist is. So the person in THN, that's your first point of contact if you need any assistance. And then if you click on resources, you'll see a bunch of links to our website, including finding doctors, guidelines, KPN access requests, and stuff like that. So we're very excited about this. We do have version 2 that are coming out. This was rolled out very quickly during the pandemic to try to help communication with our THN providers. So it does need some improvement, and we're working on that. 2020 dues are waived by the operating committee and the board of managers. I want to be sure to announce that. If you think those hands are praying, they're not, unless you want to pray thankfulness for that, they are clapping, or whatever you think is appropriate. So again, 2020 dues are waived. So if you've been waiting for the bill from us, you're not going to get one. And then finally, one other thing I want to do in the odds and ends is talk about physician onboarding. We do have an onboarding requirement now in THN. This has been communicated before, but I just want to review that if you're a CHMG provider new this year, or a physician new this year, that we need you will be participating in a live orientation program. You may have already heard me give that presentation. And we will have a live presentation, a couple of them later in the year for those who are in independent practice and who have joined our community and THN. After that, you need to see a couple of videos, one on RAP and one on the CAP survey. Remember, I was talking about surveys a little while ago. And once you've done those tasks, you are now eligible to participate in THN bonuses. Macro, of course, is always going to be there, but you would not be eligible to participate in THN incentives if you're a new physician starting in 2020 without going through these tasks. So we will communicate more about it. Why are we requiring that people do this? We have somewhere between $800 million and $1 billion in healthcare costs going through THN. And the success of our contracts really depends on how well we perform. And so we are really dependent on our new physicians learning what we're doing within THN as quickly as possible. So we are going to be working on that, and this is our first chance to try to let people know what THN is all about. Finally, let me look to the future. What's going on in the rest of this year and into next year? The first thing is we will be improving the referral management system. We are particularly aware that sometimes consult notes are not being attached by the specialist office when they are clicking done. So we're working to try to be sure that that occurs. So I think you're going to see some improvements and some early reporting that will start coming out about how promptly our specialists are seeing patients. So more to follow on that. I also want to tell you a little bit about the revenue side of THN. I think this is pretty exciting. Here we see the revenue in THN from fiscal year 12 up to fiscal year 20. And what we see is a steady increase. We had a little drop last year. We estimate that our fiscal year revenue for our year-end fiscal year revenue for fiscal year 20 will be somewhere a little over $50 million. So that's why I'm pretty confident that that incentive might be more than $9 million. And the other great thing is that at the end of this year, we will have paid Cone Health back for their investment. So we're going to pay back the rest of that. As you know, they eventually had loaned us almost $20 million to get started and be successful, and we're about to pay all that back. So we're very, very excited about that. So great things happening in THN as we move forward. NextGen. So you may have heard in the past that NextGen was going away on December 31st of 2020, and that was true until recently when CMS said, we better continue it for another year because of COVID. So that is going to be in place for another year. We are looking at some options after that. One is called direct contracting, and one is called the Enhanced Track MSSP, Medicare Shared Savings Program. You'll recall that we were in an early Medicare Shared Savings Program before NextGen. And so we'll be making decisions about this and communicating that at the appropriate intervals. But if you heard that NextGen's going away, it's true, it is. We'll have something in its place for NextGen. And of course, our Medicare Advantage and commercial plans remain intact, regardless of what happens on the CMS side here. Speaking of commercial side, I want to talk for a moment about a company called Bright Health. Bright Health is an insurance company that's new in our area. You probably all know what Blue Cross and Blue Shield did with Wake Baptist with our exchange lives. THN lost between 6,000 and 8,000 covered lives when Wake Baptist signed an exclusive contract with Blue Cross Blue Shield for the exchange. They priced it so low that people had no choice but to go with them. 8,000 patients of ours that had to move, having to travel to Wake Forest for some of their care, or to Winston-Salem for some of their care. We've been concerned about that both at the Cone Health level and the THN level. So Bright Health is a company that's come in to help us develop a exchange product that we think will be competitive with Blue Cross Blue Shield. So our goal is going to be to try to get these patients back. Bright Health is being offered through THN. Karen Bradish, our contracting director, has probably already sent some stuff out to you, or it will in the near future. We want you to think about this carefully and really strongly encourage you to join us as we try to fight to get our patients back. And then finally, I don't have a slide for it. There's a big thing going on, right? There's been an announcement of a letter of intent for merger between Centera and Cone Health. So what's the effect of that on THN? If you want to know the honest truth, almost nothing right now. And I'm not even sure there'll be a big effect for the intermediate term. Bright Health, Centera is in another part of the country. It's in Virginia, right? So healthcare is local. Physicians and providers and systems, local systems, have to get together to solve the healthcare problem in their community. We don't think Centera is going to be telling us what to do about this, mainly because we're doing better at it than they are. I think they're going to be very interested in learning from us how to manage and apply value-based principles and to do well in this emerging value-based world. So if you've wondered about what Centera might happen with THN because of the Centera Cone merger, I want to assure you that I think the answer is largely not much. It will give us some ability, perhaps, to do some things on the health system side in terms of new initiatives and stuff like that. And THN will be at the table as we do that. So thanks for your attention. I know that was a little long, quite a monologue there. Sorry about that, but thanks for listening. I really appreciate everything you do for THN. This is a great medical community, and you're a major reason that that's true. So thanks very much. So with that, I'll turn it over to Rob.
Hey, Rob, you're on mute.
Okay, hold on.
We can hear you now.
Okay, thank you very much. So let's try that again. And
You're looking good there, Rob.
okay, thank you very much.
You're back on mute. Rob, you're back on. There you go. Okay.
Yeah, all right, thanks.
Yeah.
Very good. Ladies and gentlemen, sorry for that stumbling start, but it's good to be with you this evening. I must tell you, I do miss your faces. This WebEx presentations are fun and interesting, but there's obviously some technical glitches and not much interaction between us and you guys, and so I miss that. But well, there's been an awful lot of changes since last time we got together. That don't have to tell you that. We've got COVID-19 and this whole RAF discussions talking about RAF in a COVID-19 world. Basically, for our practice, the world turned upside down around March the 18th. And at that time, we suddenly had to scramble, try to figure out how to incorporate telehealth into our practice, provide care for our patients, and stay financially viable, stay afloat. And I got to tell you, RAF is something I really enjoy. I'm kind of nerdy about it. It was not the first thing on my mind during that time. It was like, and just trying to stay alive. And looking back, perhaps not all of us were doing that much work or being that careful about keeping up with RAF. So coding may have decreased a bit during that time. And not everybody jumped in on the telehealth route. Some said, hey, we're just going to stay here. We're going to hunker down, do it in our office. And that's great for capturing RAF if the patients come in. But, you know, patient volumes did decrease because patients were worried about COVID-19. When that happens, RAF code capture and recapture also decreases as well. And as you know, to get RAF value, we actually have to see patients in a face-to-face kind of encounter. In the office, that works. That's the gold standard. And if you see the patient through a telehealth visit, as you know, particularly those that are doing this, as long as it's a video face-to-face telehealth visit, that RAF counts as well. But unfortunately, CMS has yet to indicate whether or not the audio-only telehealth visits, the RAF that comes from those visits will count. Right now, it doesn't look like it will. So I mention that just to let you know that if you're doing telehealth, please make sure you've done everything you can. Try several different video options before dropping to audio only. It is true, Medicare will pay for audio only, but our RAF values will drop. And we are, compared to the other ACOs, it's a zero sum type game. And so the better we do at capturing things through face-to-face encounters, perhaps our other ACOs competitors won't do as well. That'll be good for us. Oh, and one more word. For those of you who didn't anticipate being a first-line IT tech, which I think many of us have had to be while we're doing the telehealth, thanks for all your hard work on that. I know that's not easy. I know that personally. So, graphs down. What can we do? Well, basically, we've got a new normal that we're living in. It's not as shocking as the first week of April when we're still trying to figure out what end is up. So if you've gotten your feet under you now, we need to be more diligent about capturing RAF as we see Medicare patients for the rest of the year. That may be actually adding some RAF codes to patients that come in for acute care visits. By and large, I tend to save my RAF coding for AWV visits, physical exams, chronic care follow-up. But some of those patients didn't come in, won't be coming in. I saw a patient the other day for follow-up on diabetes, hadn't been seen in a year. There's going to be other patients that missed the boat. So if we can see them, and particularly if we can see that they haven't been seen in, since 2020 started, do the best you can to grab some of the RAF that you know is important for that patient. And it's not as hard as it sounds. It sounds, cumbersome, but documentation, it doesn't have to be extensive. You just have to kind of mention why that's important. And we typically consider a lot of the patient's comorbidities anyway when we formulate our diagnoses and our treatment plan. Might as well get credit for it. Here's an example of that. We got Mr. John here, who's 67 years old. He's got these symptoms: headache, cough, occasional pain, inspiration. Now, this is a pre-COVID example, so nowhere do you see COVID-19 testing. He might need it today, but he didn't in this example. His problem list has got the usual suspects up there. He's on those medications, and diagnosis is viral infection, hopefully not COVID. Taking Tylenol, Delsum, right? What's the big deal? Well, he's got other things that are impacting his health care. He's got high blood pressure. He's got a cough. How about that? He's on lisinopril. Maybe that's causing his cough. Got to think about it. He's got a history of CHF. Maybe some of his symptoms are related to fluid accumulation. Maybe he needs some Lasix. He's got AFib and is on warfarin. Well, that's why we can't use non-steroidal anti-inflammatories in this case. Could have been chronic kidney disease, but that's why Tylenol is recommended. And then type 2 diabetes. It's already tough when you have type 2 diabetes. Infections go on longer. We're going to want to use sugar-free medications if we can. So, those are the things that we kind of inherently think about when we're talking to patients that have a lot of comorbidities. If we're thinking about it, if we put that sort of stuff down, it shows we thought about it, and we get the RAF for it as well. So what's new in RAF? I always like to try to jump in and say, hey, this is something new. Well, COVID-19 is new and not a big surprise. We got a new code that's U07.1. I suspect many of you have had a chance to use that. Okay, but what's the RAF value for COVID-19? 0.00. So what's the deal? This is something that's caused, 3/4 of a million deaths worldwide. How can it be possible that something like this deadly, has a RAF value of 0.00? Well, remember, RAF is a predictor of future financial costs, not the present day costs. Yeah, it's expensive, but we know that for today. But RAF is really a predictor of future costs, and we don't know about those costs yet. We don't understand the future of COVID-19. We know more and more as time goes on, but we really don't know the future impact yet. Also, remember, of course, many patients that have COVID-19 are asymptomatic. There's no real appreciable risk for somebody that has no symptoms and is not going to really get bad, that we can tell. So that also complicates how to figure out what their future financial costs will be just for being positive for a COVID-19 infection. For now, RAF assigned to patients with COVID-19 is really based on the associated illnesses. And for those patients that have severe disease, that'd be pneumonia, hypoxia requiring intubation, kidney failure, when they're not eating or drinking because they can't taste anything, all of that stuff. So COVID-19 really kind of opens the doors to these associated illnesses, and the RAF associated with those is dependent upon how sick the patient becomes. And over time, they will figure it out. They'll assign some sort of RAF value to it. But remember, it took them a while to even figure out how to assign RAF to dementia. So we'll give them a little bit of time to figure this out. Something else that's not new, but it's something we haven't presented before. And I think it's a really great idea for us to know more about this and try to capture this on a consistent basis. This is acquired thrombophilia. And this came around and I thought, what the heck? Thrombophilia. Well, it's any condition that increases the chances of patients developing blood clots. Okay, so there are congenital instances of that. Factor V leading, there's protein C and D deficiency, all this other stuff. Doesn't happen very often, so what's the big deal? Well, you can acquire something that will increase your chances of developing blood clots, hence the acquired thrombophilia. What causes that? Well, metastatic cancer, yeah, pregnancy, atrial fibrillation. Now, interesting. We got a lot of people with atrial fibrillation. And we know that AFib puts people at risk for developing blood clots. Thus, we put them on anticoagulants. Well, that makes AFib something that causes acquired thrombophilia. As a result, we all need to add D68.69 to our assessments when we have patients that have these kind of conditions. And why should we do this? Well, two reasons. First off, it more accurately reflects what's going on. We would all understand if a diagnosis of atrial fibrillation was followed by put them on Xarelto or some other medication. But if we list that as something to treat the acquired thrombophilia, it actually makes more clinical sense. It really kind of shows our work, if you will. So it more completely reflects the patient's medical status, their future financial risk, and by the way, it has RAF value that's almost 2/3 as much as a complicated diabetic. It's going to generate additional revenue so we can take care of these patients. What to look for? Well, a real good place to look is anybody that's on an anticoagulant, that they're on Coumadin, Plavix, Xarelto, Eliquis, Pradaxa. Something caused them to be on that. That's the something that caused the acquired thrombophilia. And one more thing. Guess what else can cause acquired thrombophilia? COVID-19. Yeah. In the inpatient setting, patients with severe COVID-19 infections leading to pneumonia and hypoxia can demonstrate elevated D-dimer and fibrinogen levels. Also, a recent prospective autopsy study of consecutive COVID-19 deaths found that thromboembolic events to be a very common cause for mortality. So we know about everybody being intubated and having the respiratory problems, but hypercoagulable states for our inpatient patients with COVID-19, also a huge problem. Even outpatients, to a lesser degree, can have a problem with this. There seems to be the presence of an activated underlying inflammatory cascade, and that predisposes patients to these thromboembolic events as well. By the way, also so does fatigue. I mean, you probably have taken care of a lot of patients with COVID-19. I actually had a brother-in-law who just got over COVID-19 about 2 weeks ago. One of his biggest problems was he couldn't move. This guy is big, he's strong, he's muscular. I wouldn't want to take him on. He could barely lift his head off the pillow when we would call in and check in on him. So if being immobile for 5 to 7 days in a row increases your chance of blood clots, which it does, there's a lot of reasons why COVID-19 could cause this. So look for anticoagulants. Make sure that you got that diagnosis down, D6869. It's actually pretty easy to remember. Okay, well, this is the part where I want to kind of say, hey, we need to make sure we not only capture, but recapture those important RAF codes between now and the end of the year. This is a review, so I'm not going to spend a lot of time here, but this is available not only if you'd like the slides, but at some upcoming RAF academies. More about that in a moment. Morbid obesity. You guys know this. BMI is 40 or above, or that smaller, the lower weight category. as long as it's linked to 2 other comorbidities, and those are the ones right in front of you. It still amazes me how often people will have BMIs and certainly 2 or more of these comorbidities and still not be picked up. I think it's still because it's so pervasive. Well, anything you can do to kind of alert yourself that this may be a patient with morbid obesity, definitely do it, because this is an important diagnosis. It does affect all the other stuff, high blood pressure, diabetes, all the things you know. And I think it's a serious medical problem, so we need to treat it like that. It also generates RAF. How about complex diabetic codes? Many of you have heard me say, I'm not sure there really is an E11.9 uncomplicated diabetic out there. There probably is, but it's a lot fewer than we actually diagnose. So I'm saying, hey, just say no to E11.9. Do not choose uncomplicated, because I'll bet you if you and I sit down and look through the chart, I could find the complication. First, look for the classic complications. These are the ones that we call with complications. So diabetics with CKD, with retinopathy, with neuropathy. These are the ones we all know about, and use them because they're less complicated. There's no linking. It's a slam dunk. If they don't have one of those classic conditions, please don't just default to the uncomplicated E11.9. Choose E11.69, add in that 6, or sometimes for blood pressure, a 5.9. And these are type 2 diabetes mellitus with other specified conditions. What's the big deal? Well, this compared to the classic ones, you do have to link just like you do with morbid obesity, but you only need one condition. And the way you need to put it down in your assessment is at the bottom of a slide here where it says type 2 diabetes with other specified conditions associated with hyperlipidemia mixed, or a whole lot of other diagnoses like these. It could be with sleep apnea. So Jim Osborne can even point to them and say, hey, I'm treating for sleep apnea. They need to be a morbid obese patient. Or they have reflux, or they have fatty liver disease. I mean, there's a ton. And so if you see an E11.9 on your code list, first, if you know that's not supposed to be there, just make it go away. Or if you have patient or lab technicians in your office that are pulling a diagnosis just so they can get the A1C started for you ahead of time, make sure they're not grabbing this and using the E11.9. It's easy to do, but it's not accurate. And if in the same note you put E11.69 and they put E11.9, theirs is going to win. It'll cancel it out. Now, if they're in different notes, that's a different story. Then the higher code always wins out. But in the same note, if they conflict, then the lower code is going to win. One more thing. If you put E11.69 and you don't say what it's associated with, my coding educators will come grab me first, and then we'll ask you, please, to make sure you define what made it the specified condition to which it's linked. It has to say what it's linked to, otherwise it'll get kicked out. All right, so speaking of audits, which is what we're talking about when they do find these sort of things, what does CMS like to audit? Well, they like to audit a couple different things, and just heard from a conference last month, they really are looking carefully now at the active versus history of type diagnoses. So active cancer versus history of cancer. Very, very important. Patients, the bottom line is that patients are still receiving treatment, use the diagnosis of the cancer. And also if they're under active surveillance, which it doesn't mean they just come back for follow-up. It means when they return for follow-up, and it should say this in the note, that they're willing to accept treatment if after they're evaluated again, it shows their cancer has gradually or suddenly worsened. The door has to be open to them wanting treatment. So these are people that have cancer, not being treated, but are willing to be treated if it shows that they should be. So now keep in mind, once treatment's over and there's nothing else there, they should say history of cancer. And there's zero RAF for that. That's because, according to Medicare, there is no future financial cost. Well, what if they get cancer back again? Well, then you use cancer as a code again, and that's where the RAF comes back in. So know that difference. The bottom line for most of our patients is If they're not receiving treatment anymore, then it's history of. Oh, by the way, if you've got a patient who's been treated for prostate cancer, they've got the little radiation seeds. Those last 8 months. If it's been 2 years and that's been in there, you're like, I think they're still being treated. No, they're not. Go ahead and put history of, because 8 months is how long those things last. Then CVA versus history of CVA, strokes. I'm going to make a plea here. Don't use the diagnosis of acute CVA on an outpatient basis. I will tell you, 3 years ago, I got into a round and round argument with a master coder at a big conference, just convinced that, you can diagnose acute or stroke. What if the patient suddenly strokes out in front of you in the office? Well, the answer is maybe they just had a TIA. Maybe it's only going to last 3 hours and then they'll be fine. So you really don't know in that setting if they truly have an acute CVA. You send them off to the hospital, they do the studies, now they have a diagnosis of acute CVA, which is used one time in that inpatient setting. When they come back and see you and they have sequelae of that stroke, they still now have a history of a stroke. Now, not all of that means there's no RAF. If they can't move part of their body, hemiplegia does risk adjust. But do not put in your note, you saw the patient in follow-up today for acute CVA, because we'll get dinged by Medicare for that. So just in time to build on this knowledge and gain even more additional fun knowledge, virtual RAF academies are coming. And in fact, we anticipate by the end of September, we'll begin these academies on a, if not monthly basis, certainly a regular one. Because of COVID-19 restrictions, there will not be the usual nice venue and meals, but it should mean there's some room in the budget to compensate maybe for attendance. Details to follow, but I'm hopeful about that. So I want to talk about something now that we really haven't spent a lot of time in RAF academies or even in these meetings, called risk adjustment disease interactions. And there are a limited number of diseases that when you list them on the assessments, and there are other diseases that are there too, and they kind of connect up, it gives you additional RAF. So it adds additional weight or coefficients to offset the added cost for caring for members that have these specific kind of diagnoses. Not a long list. If a patient has an immune disorder and they also have cancer, you can see in the list here, and we're primarily the ones that are on the left side, the community non-dual. We had additional RAF of 0.893. Well, that's good. I don't have a lot of patients with big time immune disorders and cancer, but I do have a lot of patients with congestive heart failure. And if they have diabetes, you get the additional RAF. If they have chronic obstructive lung disease, many of them do, you get more RAF. Congestive heart failure with renal problems, additional RAF. So CHF is a biggie, and make sure that you're diagnosing that when the patient has it. Make sure somebody has sent that in to CMS during the next year, because if that one drops off, it's a big deal. I'll show you that in a moment. But in addition to those disease interactions, this year CMS is really introducing, or has been gradually introducing, and now it's a bigger deal this year, something called the alternative payment count, condition count. And although they're not adding to the disease interactions, what they are now saying is it shouldn't just be a couple codes that when you have those plus regular other diagnoses, they get some additional RAF to take care of them. Really, and this is what I think many of us felt all along, if the patient has at least 4 codes, 4 RAF codes or 4 conditions that are in separate hierarchical condition categories, they can't be like thrombocytopenia with low platelet count and cancer. They're going to be those are all kind of in the oncology section. But if they've got diabetes, they've got COPD, they've got multiple ones that are very different. If they have at least 4, the patient's going to get additional RAF and additional weighting. So you can see in this graph here, again, the category to the far left is probably the one we should focus on the most. If they have 4, you get another 0.006. Big whoop, not a lot. Well, there's a lot of patients with 4 conditions, but it gets better. If they have 5, now it's 0.042, and goes all the way up to 0.505. additional RAF plus the RAF that's associated with those diagnoses if you get, top 5 in a row. I've got colleagues I know that are seeing patients. There's 12 to 15 paragraphs in their chronic follow-up note. Yeah, those are patients that are perfect for this. Well, let's see what kind of impact that has. This is impact of non-recapture of chronic conditions. And the one I'm going to focus on is congestive heart failure, because it probably has the biggest impact. So this is Mr. Robert Jones. He's 77. And since he's 77, he starts off with a coefficient of 0.473. That's just because he's male and he's 77. In 1918, I'm sorry, that was a long time ago. How about 2018? In 2018, Mr. Jones had 5 conditions that were identified: type 2 diabetes, CKD, hyperparathyroidism, CHF, and COPD. Now, in 2019, the next year, he saw his primary care doctor, and documentation supported the diabetes and the COPD. Then later on in July, he saw his nephrologist, who documented CKD, type 2 diabetes, and hyperparathyroidism. Nobody diagnosed and documented congestive heart failure. Maybe he was doing well. Didn't see his cardiologist that year, I guess. Well, what was captured and what was not recaptured? What was captured was, as I mentioned, the type 2 diabetes, COPD, and the others from the primary care and nephrology visits. Gives you the coefficients right there. What was missed? Well, first off, the disease interaction RAF was missed. So all of those things on the left-hand side, those 3, gone. How about the new condition count? Yeah, it would drop from 5 down to 4. At 5, the patient was at 0.042. Now down to 4, you know how low that was, 0.006. So all of that's gone. What does it do to the patient's count? Well, started off with a raw RAF score of 2.398. Not bad. And there's, if you capture all of that. What's the impact of missing just congestive heart failure? Well, not just the RAF from CHF, but also you missed all those disease interaction RAF weighting, and also now the condition count dropped down to 0.006. So a huge impact. And there's a lot of times where I'm thinking, the cardiologist must have listed congestive heart failure someplace. Not always. Sometimes the patient comes in to see the cardiologist for some other specific reason, and maybe they talk about their congestive failure, but the patient's doing fine. Continue your Lasix. Doesn't get listed. We need to always make sure that we list those sort of things that have that kind of impact. Well, what would be the impact for an ACO? Let's say we've got an ACO that has 100,000 patients that are participating in risk adjustment contracts. And let's say that 30% of those patients, to keep the math easy for me, are previously diagnosed with CHF. So let's also say that we did pretty good. From one year to the next, just 5% were not recaptured. That's 95%. That's pretty darn good. I mean, when I went to school, if I got a 95, that tended to be an A. So I'm feeling pretty good about that. What's the impact? 5% that were missed is 1,500 patients. Well, CHF, you see in the top line, has a revenue impact per member per year of $3,178. Multiply those two together, you get $4,767,000 per year. That's a lot of money. And that's the sort of thing that if we are diligent and definitely make sure we capture every year, that we can hang on to. RAF is a great way to generate revenue, to take care of the patients, do all the things we need, but we have to make sure we see the patients and we recapture it. By the way, what's the average ACO recapture rate? Actually, in the low 80s. And where are we today? Well, I don't have all the data from all the different plans, but I do know, because I was at a committee meeting 2 days ago, Humana says we're at about 67.36, which is not terrible for this time of year, but it's not where we were last year, and that's probably true across the board. So I'm just saying we've got some work to do. And if we do it and just do it consistently, I think we're going to end up doing fine. And that's what I have for you tonight. Now I get to introduce a very high quality speaker, on quality. This is Beth Hodges. She's going to guide us through those important changes.
Well, thank you, Rob. That was a great introduction and a hard act to follow so far. So I'll try to keep this relatively brief for everybody. I know it's been a long day and probably a long week. We're going to talk about a few quality metrics today, just catch you guys up on some new and old issues. Starting off with SUPD. This is statin use in persons with diabetes. It is a triple weighted metric now. CMS has threatened it for years now. They've done it. It can be done, met with low intermittent dosing. So if you have a patient that's only willing to take 5 milligrams of rosuvastatin 1 day a week, that will close the metric. But remember to write the script the way the patient agrees to take the medicine. So if they only want to take it once a week, give them 13 pills, which is a 90-day supply. A question I frequently get is, but my patient's LDL is 40, they don't need a statin. According to CMS and recently published data, they do need a statin. A low baseline LDL does not exclude a patient from the metric, and studies have shown that even people with low LDL have a 21 to 28% decrease in cardiovascular and cerebrovascular events if they're on a statin. So they do need to be on one. For the SUPD measure, a diagnosis of myalgias and myositis will not exclude the patient from this metric. And that's because they set the bar so low to close the metric. They don't feel like they need to give us a lot of outs. This diagnosis of myalgias or myositis will work with a diagnosis of SPC, which is the metric for statin use in persons with cardiovascular disease, but it does not work for SUPD. The only exclusions for SUPD are hospice enrollment and end-stage renal disease. Emma, next slide. Thanks. Now, statins for persons with cardiovascular disease. This is anybody with documented cardiovascular disease or vascular disease, ages 21 to 75 if it's a man, and a woman aged 40 to 75. And the reason for the difference in the two is obviously women of childbearing age. It requires moderate to high dose statin therapy, but does not specify the frequency of dosing. So you can use 20 milligrams of rosuvastatin once a week and close this gap. Remember to write the script the way the patient agrees to take the medicine, because otherwise what's going to happen is if you give them 90 tablets and then they come back to you next time and say, but doc, I'm only taking it once a week, they've got enough for like 3 years, and you're going to fail the metric until they fill the medicine again. Remember that these metrics are closed by pharmacy claims. So if the patient does not fill a claim, it does not matter what your chart says they're on. According to CMS, they're not on the medicine. This is a graph that tells you which are the moderate to high dose statins, and I believe we'll probably email these slides out to you so you can cut and paste this if you need it for your reference. It also has been in the Beacon recently. And you can find prior issues of the Beacon on the THN website under provider section under newspaper or newsletter resources. Next slide. Now let's talk about osteoporosis. Women aged 65 to 85 with a fracture must have their osteoporosis risk addressed within 6 months of the date of the fracture. So if you fracture it on your femur on January 1st, you have until about July 1st to close the metric. There are two different ways that this metric can be closed. One is by obtaining a bone mineral density test, and the other one is that the patient files a prescription claim for an osteoporosis treatment. It can be Fosamax, which is the easiest and fastest thing to file, but not necessarily the most efficacious, but it's a good way to start. And a lot of plans will require that a member fail Fosamax due to side effects or efficacy before they'll pay for one of the more expensive medications. Prolia is, of course, a very efficacious medicine, but also one of the more expensive ones. It has been suggested, and I think this is a reasonable suggestion. Let's say you have a patient with osteoporosis, go ahead, get them on Prolia. But in 2 years, if they've been on it and now they're measuring in the normal zone with their bone density, then maybe consider switching them to reclass at that point to save pharmacy dollars. And we'll talk about that more in a few weeks when I have some more data to present on this. Remember that estrogen and vitamin D do not count to close this metric, so it's got to be a prescription medication. Now, in terms of the bone mineral density, a lot of patients will tell you, I just fractured my leg, I don't want to go get a bone density. Well, that's fine. They don't have to go to a breast center or hospital to get a bone mineral density. Remote Health, which Dr. Osborne was talking about, they do have access to THN's portable bone densitometry machine, and they will go out to your patient's house free of charge to the patient. And they will not only do a bone density that they will send to you, but they'll file the claim so you don't have to worry about the gap getting closed. And they also do a really excellent job of educating the patient about osteoporosis and why this is such an important thing to keep them from having another fracture. So consider asking Remote Health to help out if you need it. If you're not sure how to do this, just contact your practice liaison and they can set that up for you. I also call your practices from time to time. If you have somebody that's in the OMW gap that has a measure that's not closed, I'll call the practice and ask to speak to you or maybe your practice manager to urge this, because a lot of times PCP is not aware of the metric needing to be closed in a patient because the patient doesn't come to see you and you don't know that they fractured something. So when you get those phone calls, please do try to help us close those metrics because we're usually on a pretty short time frame to get that done. Across all plans, diabetic eye exams are very low completion this year due to COVID and a lot of eye professionals' offices being closed. Patients do not understand how important their diabetic eye exams are to preserving their vision until they wake up one day and they can't see. So please do try to encourage your patients to get their exams. Pick up the phone. A lot of these offices that are open are only scheduling emergencies, or they're scheduling out several months and might not close the metric in time for your patient. So please consider calling the office and explaining it's a diabetic. I need them done before December 31st. And I think you'll find that most of the offices are very helpful. Let's talk about medication adherence metrics briefly. These are your statin cholesterol medicines, your hypertension meds to include ACEs and ARBs, and your diabetic medications not including insulin. All three of these are triple weighted, so each one is as important as 3 other metrics. Very, very important. Ask to see your reports. You may not be aware that your office gets a medication adherence metric report every month from THN. And your patients that are either have failed or are close to failing the measure will be on there. And encourage your staff to call these patients, find out what the problem is. If they can't afford their medicine, excuse me, we'll probably fail the metric this year. But if you get them involved in patient assistance, they might not fail it next year. So I encourage you to do that. I'm going to take a sip of water, excuse me. Thanks. Next slide. The controlling blood pressure metric, CMS has just recently announced that it will now accept self-reported blood pressure values from patients, but it has to be in an appropriate section of the chart. So make sure if you're having a virtual patient visit with a patient and they're telling you what their blood pressure is over the phone, that you input it into the vitals section of the office note and simply put it in the comment section, self-reported or patient-reported, so you know how you managed to get a blood pressure reading on a virtual visit. Next slide. I'll be having my COVID swab tomorrow morning, apparently. Chronic condition recapture, Dr. Reed already mentioned this, so I'm not going to belabor the point. please remember to resubmit those diagnoses. And don't forget to check your KPN point of care reports or your radiology reports for some of those diagnoses that might not have been captured yet, like aortic atherosclerosis or vascular disease. So you might be in a situation I was in with a patient today. I have a patient, she is diabetic. She is uncontrolled. Her A1C is 12. She hasn't had an eye exam in 5 years. She refuses to give me a microalbumin because she just can't pee in somebody's office. She has never had a mammogram and will never have one. She doesn't want a bone density. Colonoscopy, forget it. Don't come near me with a stool card. You're not doing a pap smear. This lady is very frustrating. The reason she feels this way is she's got a lot of psychological and physical problems. She's dealt with pain her whole life. There's some distrust with the medical community as well. She realizes she doesn't have a long lifespan and she doesn't want to do anything that might accidentally prolong her existence. So I made a deal with her today. She and I agreed that she could have a palliative care consult. Now, do I think that she's within a year of the end of life? She might be because she's a walking heart attack, but not necessarily. Definitely not hospice appropriate yet. But she's got chronic conditions and she's got definite ideas about how she wants to plan her care. So I'm going to get a palliative care consult from a ThoraCare or Hospice of the Piedmont. And once they submit that palliative care code, it's going to remove her from almost every metric that she's not passing. And that is also going to take the strain of our relationship away because now I'm not going to hassle her as much about these metrics that I really want. And I can focus on maybe getting her A1C down and maybe getting her to try a good pain clinic. But the point is, if you get a hospice consult or a palliative care consult, it will remove a number of the metrics that we normally have to do on patients. And sometimes patients are just not appropriate for preventive care or aggressive care. And you don't have to feel guilty about that, but please help us take them off the list. Next slide. So how can you stay up to date on rapid changes in THN? Please read the Beacon. Every Beacon issue that comes out every 2 weeks has something new in it that we haven't told you before, and it probably has 5 or 6 things. So please read every time. It doesn't take more than 5 minutes to skim it, and if you can click on links and go deeper into something if you have more questions, and we're always willing to to answer and add to it if you need more information. Also, as Dr. Osborne mentioned, your elite primary care quarterly meetings are very important. And most of the time we're meeting with office managers, which is great, and they get great information, but they're not providers. They're not billing every day. They're not doing the things that we need you to do. And so if you're getting some of that information third hand, you might have questions that they can't answer, or something might get misrelayed. So please do encourage your office managers to schedule those elite primary care quarterly meetings at a time that you can attend and be a representative of providers in your office. And I think that's all I had to say. Oh, pharmacy consults, yeah. Do not forget that the quality department has hired additional pharmacists to provide support THN practices. You'll see notices that your office gets from these additional pharmacists that Mr. Smith is not on a statin, and is there a reason that you can tell us why he shouldn't be on this metric? Well, not only are they reminding you about Mr. Smith and his statin, but they're willing to call Mr. Smith themselves and offer an outside opinion. So all we ask is that you tell Mr. Smith and get his agreement that he can be called by a pharmacist, so he answers the phone and doesn't think the person's up to anything, untoward. And then fax the referral form to care management. In the comment section, say pharmacy, SUPD, or SBC, or whatever, statin therapy, we'll take it from there. Okay. And I will pass the ball back, and thank you very much.
So Dave, I think we've got just a couple of questions if we want to kind of run through those.
Yeah, sure. Dr. Cox has been waiting for an hour for questions to be answered. So let me do these two quickly, and we'll encourage anybody else that has a question to go ahead and type it into the question and answer session, and we'll stick around and one of us will do our best to answer those questions. So how does remote health vary from Landmark? There is quite a bit of overlap between those two programs with regard to the targeted patients and the services that they provide, but they are very, very distinct. Landmark is a national organization that was specifically contracted by Health Team Advantage. So right now within THN, those are the only members they see. And of course they co-manage with the PCP, about 15% of the HTA members that are the most complex. And they bring a whole team, a physician, behavioral health, social worker, nurse practitioner, et cetera, to that encounter or to that patient to wrap around those services. Remote health is really a smaller, locally grown group. This is led by an extremely energetic and very experienced geriatric nurse practitioner. And so I would consider this kind of a Landmark light, and it's going to really augment those services for HTA and then provide some services for patients that are not within the HTA. And the second question is, how will the patients we lost to the Blue Cross Blue Shield plan to Baptist find out about Bright Health? Are we able to send information about this new plan directly to these patients? Well, we indeed lost, I think, about 8,000 members, patients within our community to that plan. So you can bet there's going to be some co-marketing between Cone, THN, Bright Health within our community. I think we have to be a little careful as providers to recommend a particular plan to a patient, not knowing everything about the plan and or the patient's specifics in terms of the maximum out of pocket and all those nuances. But I think it'd be very reasonable to send these members a letter and say, we miss you. We are participating in a new plan coming into our community. We hope you'll check it out. We hope you'll discuss this with your agent and see if this is appropriate for you. But there will be plenty of outreach and marketing. And then this next one, I will definitely turf to Dr. Beth. Dr. Matheny is asking, do you have a link to the study or studies with regards to the CV risk reduction for patients taking statins less than on a daily basis, Beth?
Yes, the data was on up to date, and I can get you that information.
Also, Dave, there was a question about stopping statins in geriatric patients.
Again, I'll defer that to one of my distinguished panelists.
I'm sorry, I can't see the questions.
Yeah, I'm not seeing that either. Is that in the chat rather than the Q&A?
Yes, they sent them straight to me. I sent you some, Dr. Grapey, in the chat.
All right, I need to open up the chat because I just have the Q&A opened up. Let me see.
Mine are not showing.
I just sent them to Dr. Grapey. Hold on, Dr. Hodges, I'll send it.
If you want to read them off while I'm getting this chat up, go ahead and take the next one, Emma. I know we're kind of short on time, so.
All right. Dr. Reed, if a patient on an echo has a diagnosis of GREAE1 diastolic dysfunction, but no clinical diagnosis of CHF, should we add CHF to our problem list?
That's a really good question. Quite honestly, I suspect that the cardiologist may have ordered the test, but if they didn't, and if you have symptoms that fit with diastolic CHF and you go, that makes sense, that's what I thought was going on along, then by all means, especially if you're treating it. So yeah. Now, if a cardiologist ordered the test, then it's not a bad idea to check their notes out, see what they had to say. They probably would have mentioned that as well.
So I see this now, Emma, thank you. So there's a question about the coverage for acupuncture, and certainly it's an important tool, especially for those with chronic pain. It is, fortunately, Medicare now has a new ruling that acupuncture is going to be a covered service, and so MA plans have to follow that as well. So I know for Health Team Advantage, that will be a covered benefit for 2021. I don't, off the top of my head, all the specifics with regard to the length of coverage, but it is a covered service now and will be available. So that's, I think, going to be a nice addition to the armamentarium to help some of these folks with some of these chronic pain conditions, as well as a few other things.
I have a little information on that, Dave. I think they approved somewhere around 8 visits. If it's not 8, it's in that neighborhood. So just to let you know.
Okay.
There's a question. So we have been working on capturing aortic atherosclerosis. Is it correct to say that we will get dinged if the same patient is not on a high dose statin, moderate to high dose? Yes. That usually, they don't enter that denominator until the following year after the first year you capture aortic atherosclerosis, but it is vascular disease, and it is one of the literally there's about 100 codes that will classify someone as needing a statin for cardiovascular disease. So yes.
I know this kind of bridges between what Beth talked about and what I talked about. I mean, that's an important RAF code. And in fact, our radiology buddies have identified it in thousands of patients that have had CT scans. We need to look at those CT scans, or even put in a separate section at the bottom, lift that out, put it on our problem list. And when we see the patient, we need to include it. But yeah, what do we do about this if we're not treating it? I'm going to make the pitch that we treat it, at least with weekly statins. What is it telling us? It's telling us that these patients have really gummed up arteries, and we should probably have them at least on some medication that'll decrease the chance of that worsening. Treat it, please.
In meta-adherence reports, more than 50% of the time patients state that they have excess meds at home they're taking every day, and that the mail order insurance company has sent, quote, too many. Seems to be mail order pharmacies. Humana is the biggest culprit. Suggestions. Well, one thing is that the mail order can't send refills if there aren't excess refills on file. So how I tend to kind of handle that is I'll give patients 90 days with just one refill. That way I'm looking at that and updating it every 6 months. That's just how I tend to handle it. I don't know if Dr. Reed has any suggestions.
No, I completely agree with that. I mean, sometimes patients will forget that they have another refill, and maybe there's one there at the pharmacy. They'll call in. We have a refill nurse. She may not have noticed it also, and possibly sends in another. I mean, I can see how multiple prescriptions would come in, and that could be problematic. Another thing, by the way, something Kevin, one of our THN pharmacists, reminded me of that I don't do near enough is, let's say a patient's on 50 of losartan and they've been moved to 100. I need to not only send in scripts for 100, but in that append a note that says, please cancel any additional refills for the losartan 50s. Otherwise, they end up getting those too. So,
yeah, that can be a particular problem with automatic refills, and so the patient may get another 50 shipped to them, even though they've got hundreds.
Right.
Was there any more questions, Emma?
Yeah, Dr. Howard had a couple of questions there. How about chiropractic for back pain? I think he's asking, is that a covered service? Dave, comment?
I think for Medicare, chiropractic coverage is only for some very specific diagnoses. But that's a good question. I can certainly follow up and get the very specific coverage for our community with regard to that across a variety of plans.
And then Dr. Howard, we'll be happy to have you participate in the education for Joint Strong. So we're looking for people to participate. Thank you for your interest. We'll be in touch. Thank you very much. You can actually download the app right now and take a look at it. if you want to, and just kind of see the experience that patients might have if they do some self-care with it. But we'd be happy to have you. And if others of you are going to be interested in participating in that, please let us know, because we do have opportunities to get people trained at THN expense. It's going to take a few hours of your time to get trained up, but I think it'll be really worth it for you if you would consider doing so. So you can email me here or tell your practice performance specialist. Thank you.
And just real quick, I'm sure everybody saw that the CDC is sort of predicting the worst flu we've ever seen here in the next few months. What THN is trying to do is really be proactive in our approach to helping our offices, and we didn't want to just give you a solution without talking to all of you about what you might need. So the practice performance specialists are going to be going out to the different groups with just a 5-question questionnaire, and really asking about plans for the upcoming flu season. If you're offering the high dose only shot, what your usual protocols are. If you have interest in THN giving you kits to give your patients with things like hand sanitizer and masks and COVID and flu information. And then just what can we do overall to help your practice? So be looking for that over the next week because we're really pushing this along, and we want to get all those answered by the end of next week. So thanks for helping us out on that.
All right, it's 7:32. I think we've reached the end of our time. Thank you, everybody, for your participation and listening and your good questions. And always, you ask great questions. We, again, appreciate all your work, everything you're doing for THN. It's absolutely critical in our success. We literally would not have an ACO without you. And so we don't take that for granted. We want to assist. We want to help you in every way we can. We want to help the patients do as well as they can as well. So have a great evening, a great weekend, and everybody take care. Bye-bye.